Today we're going to talk about next part. Last time we've been talking about gram-negative cocci or Neisseria genus. Today we're going to talk about gram-positive cocci and their importance in our clinical life. So, also last time we discussed about the importance of making difference between gram-positive and gram-negative bacteria, right? So, if last time we mentioned that gram-negative bacteria, and specifically gram-negative cocci Neisseria genus, are extremely susceptible to the environmental factors which make them non-resistant in the environment, which is really good from epidemiological perspective. So you need really close contact to a source with a source of infection in order to get infected. If we're talking about Neisseria genus more specifically, not all gram-negative bacteria. Okay, Neisseria genus. If we're talking about gram-positive cocci, which are making part of most of infections we have on our daily basis, I'm talking about bacterial infections, because on the first place by frequency we have viral infections, on the second place bacterial infections, and on the third place fungal infections. So bacterial infections are situated on the second place after viral infections by frequency. And on the first place, according to statistics, are caused by gram-positive cocci. Now, I told you that it is really easy or comfortable to determine difference between different type of bacteria according to their genus name, their shape, their arrangement, and other morphological features. So, talking about gram-positive cocci, they are really resistant to the environmental factors comparing to gram-negative cocci, which makes them more dangerous from epidemiological point of view because they can persist basically everywhere. This is what makes them to be normal representatives of our environmental flora. So talking more specifically about Staphylococcus, Streptococcus, and Enterococcus, all of them, they have their specific place for multiplication. And I guess most of you heard about them, right? Who didn't ever hear about Staphylococcus? Probably everybody heard. Who didn't ever hear about Streptococcus or Enterococcus? Talking about Staphylococcus, first, it is one of the mostly frequent representatives of our infections, and be more specific, both common bacterial infections and specifically nosocomial infections. Who knows any person or maybe more people with who knows more people with it seems now I will start letting students go home. Do you know the rule? If you're sick, You're not coming in the class. It is a very important rule, especially when we're talking about respiratory infections. Interesting fact. When a student has an intestinal infections, they never come. When students have intestinal infections, they never come. Meanwhile, they are not that dangerous for the society from epidemiological point of view. But you know that if you sneeze by chance, it will go in two directions. That's dangerous. Not for society, for image. However, it could happen to anyone, right? But the mostly dangerous from epidemiological point of view infections are highly spreaded for this very reason. A lot of people are really used with them. Oh, not a big deal. Somebody will say, "Oh, I'm allergic," right? It's not any viral infection or something. Especially now, flowers are blossoming and so on, right? So it's allergy for sure. It's not an infection. It's really important to show responsibility not only in wearing masks, but also in isolation and treatment. Isolation and treatment. And treatment includes not only applying of any medicines, but also taking rest. And taking rest is possible only either in hospital, either home. It depends on how bad it is. Okay? Is it clear? So if you don't feel good, I'm not keeping you here. Please? Okay? Okay. Coming back to our topic. Probably a lot of you know at least one person with chronic sinusitis. Do you know? Who knows at least one person here with chronic sinusitis? Maybe we even have here some people with this infection. So when winter is coming, if you don't put your head good enough on your forehead, it starts, right? And it continues with headaches, with some catarrhal symptoms maybe, with fever, with antibiotic treatment, right? It doesn't happen to anyone, but a lot of people, according to statistics, about 15% of adult population are lifelong carriers of Staphylococcus aureus in nasal cavity. If you have Staphylococcus aureus in nasal cavity, there is a high chance for you to become chronical infected or chronical sick person who gets sick from time to time. It is not 100% warranty for you to be sick. It depends on your immunity. It depends on some other different factors. But by the way, who wants to become a surgeon? Raise your hand, please. Okay. Okay. Anybody else who wants to become a surgeon? Okay. Yeah, on the first lecture, I asked you who wants to become microbiologist. No hands I saw. Uh, Even if you are only second year. Okay, so talking about micro. Oh, we don't know. We have 4 years more, except this year, to study, to choose, to decide what we have, what we want, what we don't. Uh, so being that polite, you show that you don't really want to become a microbiologist. That's absolutely fine. It's a boring subject. I understand it. It's it is exciting only for nerds, so that's totally fine. But you already know, a lot of you already know that you would like or you really want to become a surgeon. So if by chance you have chronic sinusitis, uh, the door into surgery could become closed to you, or you will have to pass through a lot of treatments in order to end a lot of colonizations, a lot of surveillances, a lot of investigations in order to make sure you don't present any risk to patients. Most of doctors who are working in surgical labs, not most, all medical staff, by the way, not only doctors, nurses as well, who are working in surgical staff, surgical wards, are supposed to make uh, investigation of nasal cavity for carrying of Staphylococcus aureus. For which reason? It's number one. It's number one healthcare associated infection. And here's the answer why, right? If a lot of people are carrying Staphylococcus aureus in nasal cavity, some of them are healthy carriers, some of them are sick people, and still they work in healthcare and specifically in surgical wards, because there is a huge difference. Me, for example, I don't have any direct contact with patients almost ever. And because this is my specialty, I'm not working with a patient, I'm not giving treatment, I'm working with students, I'm working with other doctors. And I don't have a direct contact with patients' blood. They don't present any or any other biological materials. They don't present any risk to me, and I don't present any risk to them in case of any infection from my side. As a result, from this point of view, both me and other patients are safe because I don't present any risk. As a result, even if I would be the person with chronic carrying of Staphylococcus aureus, there is not a big deal, right? Because normally Staphylococcus aureus and other species of Staphylococcus are making part of our normal flora. They are present not only in nasal cavity of a lot of people, they are present almost everywhere, on our skin, on our nails, in our hair, on surfaces around us, on table, on the floor, and so on. They're making part of normal flora. They are, as a result, they are really resistant, I told you, to the environmental factors. And also, since there is a rule in hospitals every 6 months to change all disinfectant substances in order to reduce resistance of nosocomial strains to disinfectant substances, which is a really big issue. Why? Because usually people are using, doctors, hospitals are using uh, same substances with different uh, trading names. That means by different brands, you know. Today it is called Pasdes. Next year it's called Tabides. Next year it is called chlorine. I don't know what, but all the time the active substance will be chlorine. It is not how it is supposed to work. So every 6 months we actually should change the active substance. Is it easy to do that? Of course not. We don't have that wide choice of disinfectant substances. However, it is hard, but it is not impossible. Moreover, different types of substances could be or couldn't be applied to different surfaces and to different tools. Not everything you can treat with peroxide hydrogen. Not everything you can treat with chlorine. Not everything you can treat with alcohol. There are some specific types of disinfectant substances that are used only for rubber, only for plastic, only for glass, only for lenses, because, for example, in different surgical specialities, we are using not only surgical tools with blades like scalpels or something, but also we are using gastroscopes. We are making we are using some microscopes in different specialities, not only in microbiology. And such devices, they have special lenses. Those lenses are making of special types of glass, and they are covered with a special substance that makes those lenses providing you with good visibility. If you will apply some aggressive chemical substances, you can damage those lenses, and you will actually destroy very precious, extremely expensive devices in few days. So for each tool, for each material, for each surface, we have different types of chemicals we can apply for this reason. So it's extremely complicated procedure to provide hospitals with all needed materials and solutions. Now, who had ever tonsillitis? Who had ever sore throat? Who had ever amygdalitis? I told you 3 times the same infection. These are 3 different names of the same infections, of inflammatory process in our tonsils that are situated on both sides from uvula. Is it clear? Did you ever have it? Who didn't ever have it? Who did ever have it? Who had it more than once? Who had it more than 2 times? Did you get it? This is an infection that affects basically, if not anyone, almost anyone. This infection is caused by Streptococcus pyogenes. There are some extra pathogens that could potentially produce this infection, but in most of cases it is Streptococcus pyogenes. So as soon as you get such infection, don't you think that, oh, probably I've been infected from someone, or somebody have sneezed or coughed and I got infected. Probably you had it, but by chance it have been activated, because this pathogen normally is present in the oral cavity of most of people. This pathogen could cause tonsillitis, this infection we discussed now. It can cause scarlet fever, especially in kids, not especially, specifically in kids. It can cause arthritis, and normally it's present in anybody's oral cavity. As a result, as soon as your immunity decreases, some people are more exposed, some people are less, but you have a chance to get this disease. So also it makes part of so-called conditionally pathogenic flora. Now, you will find in different sources, different literature, you will find some people will, some authors will mention that Staphylococcus aureus is conditionally pathogenic bacteria. Some people will, some authors will say that it is mandatory pathogenic bacteria. Some authors will say that Streptococcus pyogenes is conditionally pathogenic flora. Some of them will say it is mandatory pathogenic bacteria. Somehow, my opinion is closer to that one. It is conditionally pathogenic bacteria. Because exactly same bacteria, exactly same strain, not only family, genus, species, same strain. Someone could be affected and somebody couldn't. This is what makes difference between conditionally pathogenic flora and mandatory pathogenic flora. Because talking about mandatory pathogenic bacteria, the rule is the following one. As soon as this microorganism gets in your body, it produces an infection. Of course, it depends on dose, it depends on some other factors, but normally for strictly pathogenic bacteria, this rule is applied to any infection. As soon as it gets in your body, it produces an infection. Conditionally and the second rule, normally it is not present in your body. Normally it's present only in the body of sick people. And talking about conditionally pathogenic flora, the rule is you can live with it during entire life, and just sometimes, with some exceptions, it can produce a disease. So it persists in your body, it can multiply there, it can be even spread it and transmit it to other people. Other people could get infected and could get sick with this pathogen, but you will still stay healthy. What's the reason? Your immunity and your lifestyle, all the conditions you are living in provide you with protection against potential disease. So since most of your life, even if you are a lifelong carrier of Streptococcus pyogenes, if you're a lifelong carrier of Staphylococcus aureus, most of your life you're healthy, right? As a result, we say Staphylococcus and Streptococcus genus are conditionally pathogenic. Now, for which reason some scientists and some doctors are saying that Staphylococcus aureus, Staphylococcus pyogenes are strictly pathogenic bacteria. So, talking about the entire genus Staphylococcus streptococcus, most of them they are saying there are some pathogenic species, there are some non-pathogenic species, and there are some conditionally pathogenic species. And talking about Staphylococcus aureus and Streptococcus pyogenes specifically, they say these two species are strictly pathogenic. Why do they say so? The main reason is that since most of healthcare associated infections, that is nosocomial infections, that is infections you acquire during any kind of medical procedure. And here please pay attention, healthcare associated infection or nosocomial infection, synonyms, means any kind of infection that you acquire as a patient or as medical staff during performing medical activity. Is it clear? During performing medical activity, if anyone, a patient or medical staff, got infected during those procedures, this kind of infection will be qualified as healthcare associated infection or nosocomial infection. Of course, patients are highly exposed, more exposed to get infected in such conditions. For which reason? The main reason is that any patient who comes in the hospital, by default, you should consider people with decreased immunity. And this is condition number one for conditionally pathogenic flora to become pathogens. Clear? So, the main condition for conditionally pathogenic flora to produce a disease is decreased immunity. And the second condition, this one is optional, but in the hospital it persists almost everywhere, is an injury. That means an extra gate through which one the pathogen can penetrate inside the body. As soon as you come in a hospital, you can by default consider all of your patients to be people who fit to all conditions that conditionally pathogenic flora requires in order to become pathogens. As a result, as long as we are talking about healthcare associated infections, we never divide them in pathogenic and non-pathogenic flora, because as soon as even saprophytic flora that is not pathogenic will get into the wound, into abdominal cavity, into CSF, into the blood, and so on, it's a potential risk for infection. As soon as bacteria will get, it is the second condition, as soon as such bacteria will get in the place they are not required to be, they are not expected to be. And you should know, we have in our body mainly two types of systems from this point of view: open systems and closed systems. Talking about open systems, starting with our outer part is skin, hair, nails, mucous membranes. It is open system. Talking about mucous membranes more specifically, we have two main systems, respiratory tract and gastrointestinal tract. Both of these are covered with mucous membranes. And they're open systems because normally every day and every moment they interact with the environment. When you breathe in and breathe out, you interact with the environment, and you inhale not only clean air, not only oxygen, not only CO2, not only nitrogen, and so on. You also inhale some dust, some steams, and some bacteria. Some pathogenic bacteria, some non-pathogenic bacteria, some viruses. It depends on your environment. So normally, our respiratory tract from the nasal cavity till the bottom of our lungs are normally populated with bacteria, with non-pathogenic bacteria. Talking about gastrointestinal tract, same thing. Since we interact with the environment, we drink, we eat, we consume something, and we produce something. The mostly populated place in our body, you should know, is large intestine. The biggest accumulation of bacteria ever is in the big intestine. Some people are even trying to make it that exciting and saying that you have few kilograms of bacteria in your intestinal tract. It's not true, because most of the mass of your intestinal tract is made of processed food you consumed and intestinal epithelium, because mucous membrane is that kind of tissue that regenerates faster than anything in our body, and it changes the layer after layer much faster than your skin. For example, if you get a cut on your skin, in 1 week it's fine. Of course, it depends how deep is it, but usually approximately 1 week is enough for your skin to repair. Same thing happens much faster, like in even 24 hours with our mucous membranes. But again, of course, it depends on how deep is the injury. But every day you change the entire surface of the intestinal tract. By the way, this is the reason, and the mucous membrane is covering not only the intestinal tract, starting with oral cavity and finishing with the rectum. So also oral cavity is changing all the time epithelium. This is the reason it's important to wash and brush your teeth every day in your mouth. Every day, not and even more than once a day, because in the morning you wake up and you understand you really need it. Why? Because all the time you have some bacteria there, and that part of epithelium that is not belonging to you anymore becomes a very good food for this saprophytic flora. And you should know that in this world there is nothing that stinks but bacteria. The bacteria is the only thing that stinks in this world. Think about it. Most of people know it, but they don't realize it. So this is what happens to our body. And in order to keep it clean, in order to keep it safe from any infection, we should have some specific, some good hygienic habits. Now, since we are talking about nosocomial infections, nosocomial infections could be caused not only by Staphylococcus and Streptococcus. Actually, we are surrounded by a huge number of different types of conditionally pathogenic flora. And you will observe, if you will make a small research, at least you will try to Google to find out the mostly frequent, the mostly common pathogens that are producing healthcare associated infections, you will observe that most of them are caused by conditionally pathogenic flora. Which is the reason? First one, high resistance to the environmental factors. And in your hospital, in any hospital, you will observe that aggressive environmental factors in hospitals are much more numerous and their intensity is much higher. Think about it. For disinfection and sterilization, for asepsis and antisepsis, but specifically for sterilization, because since we are talking about infections, usually the infection is associated to some invasive procedures, injections, surgeries, some traumatic events, and so on. Some invasive procedures. So as a result, we will talk more about sterilization. We have 4 ways for sterilization, applying 4 different types of factors for sterilization. We discussed it last semester, right? Physical, chemical, mechanical, and biological. Physical. You apply different physical factors. As a physical factor, we can have temperature, high temperature or low temperature, including burning, by the way, or boiling, or applying of hot air. All of these are physical factors. Applying ultrasound. Ultrasound is a physical factor. Applying UV lamps and any other type of radiation which you can use against microbes, against pathogens, will be called physical factor, including alpha, beta, gamma, and X-rays. That means radioactive radiation. Talking about chemicals. For chemicals, as chemicals, we can apply acids, we can apply alcohols, we can apply hydrogen peroxide, we can apply what else? Aldehydes, and so on. You had it last semester, right? So different chemical substances which are aggressive to biological materials, and as a result, they can destroy pathogens. Physical, chemical, mechanical. Mechanical sterilization usually is applied as filtration of some liquids. Not everything you can boil, not everything you can burn, not everything you can treat with chemicals, not everything you can treat with radiation. As a result, some liquids, basically liquids, can be treated with filters. It's mechanical. Mechanically, you remove liquid from pathogens or pathogens from liquids by applying filtration. So you never change the material itself, the liquid itself will never change its properties, but it will be mechanically cleansed up from pathogens. And biological. Biological is applying antibiotics. Since initially antibiotics have been produced biologically by cultivation of molds, specifically penicillium, that produced penicillin, first antibiotics have been considered biological substances. As a result, applying antibiotics against pathogens, not only in treatment but also in some other procedures, can be considered as biological type of sterilization. But please don't misuse it with treatment. For treatment is not sterilization. Treatment is treatment. Okay? So, in a hospital, you have all of them. In a hospital, you apply chemicals largely. In a hospitals, especially in a dressing room, in surgical ward, in treatment room, and other wards that are related to some invasive procedures or direct contact with a wound, there you will find UV lamps, right? A lot of such wards will be provided with mechanical ventilation, maybe some of them even with filters, not only opening windows. You know, long time ago, more than, I guess it have been about 15 years ago, I've been a student, and in summer we've been present on a surgery, and since it was summer and not every hospital was able to afford air conditioning, in some surgical wards, actually during surgeries, windows have been opened. Okay, maybe not a big deal that window is opened, but when flies are entering the surgical ward, it becomes an issue, isn't it? So of course it used to be a big issue. Fortunately, now I didn't ever see something like that anymore here, but I assume that there are a lot of places on our world where issues like those could persist even till now. So what can you do with this? Because still we need normal conditions for working, and those conditions include also surrounding temperature. You cannot perform a surgery being extra hot, extra heated. So we apply disinfectant substances, and we of course largely applied antibiotics, and sometimes not really in the best way antibiotics are applied, because, and this is, I guess, the worldwide reality, most of doctors are extremely non-motivated to make lab investigation in 100% cases to any patient with any infection. Why? Most of infections are really common. most of infections, all doctors really know how to treat without any investigation. Is it good? On one side, it is good, because as soon as you can diagnose without any lab investigation, that means you have a pretty good experience. But there is something you can never calculate without, or estimate or guess without lab investigation. And this is what we called resistance to antibiotics, especially in places you widely apply them. If you apply the same antibiotic during a few years, or even maybe during few decades, sometimes even this happens, but usually drugs are updated. So if you apply the same antibiotic again and again, there is a chance that goes up to 100% that soon enough this antibiotic will not work anymore. It will become useless. Keep in mind, the mostly susceptible pathogens are rare pathogens. The mostly resistant pathogens are common pathogens. Did you get it? As more cases of the same infection you will have in your practice, as more is the chance that you will finally get a multi-drug resistant strain. Because everything that doesn't kill you mutates and tries again. This is what happens every time in a hospital. Every time the pathogen has the contact with antibiotic and you didn't make lab investigation with sensitivity test, finally you will get to resistance, because you never know exactly, specifically, which dose to apply 100%. Because sometimes you can have resistance, sometimes you can have sensitivity, but for some pathogens we also have intermediate status between resistance and sensitivity. What does it mean? Apparently everything will go fine. Apparently the patient will be treated well. But since you don't know that the patient has intermediate sensitivity to this antibiotic, your treatment could be enough for decreasing symptoms, but will not be enough to remove totally the pathogen from the body of the patient. As a result, a little bit later, after treatment, the patient will come again with the same infection. And sometimes you will think that it is reinfection. Reinfection is when you've got infected, you've been completely treated, and after that you acquired it from another source. It is reinfection. But when you didn't treat the infection completely, it is not reinfection. It is secondary acutization of the same infection. And this time the same treatment will be useless, because after time, when this pathogen already had the primary contact with the antibiotic, even such small organisms as bacteria, they have their own immune system and immune response. And if you want, this is what we call for us vaccination. Incomplete treatment with antibiotics works on bacteria as vaccination works on us. It doesn't kill us, it doesn't produce any damage to us, but it produces some special mechanisms for protection against this very infection. This is what happens to bacteria after primary non-lethal contact. As a result, you, as a doctor, should be aware not only about diseases, not only about treatments, but also you should be aware about types of investigation you should prescribe, types of pathogens that are requiring those investigations. And also you should be aware about the fact you should all the time have a reserve treatment. So if you make investigation for sensitivity, it's not enough only to find the mostly susceptible, the mostly efficient antibiotic for this very pathogen. It is not like you compare sensitivity to different antibiotics and you take the best one and you apply it immediately to the patient. If it is the only susceptible one, that's fine, you use the best one. But if you have more of them, the best one, you don't touch it in the beginning. If you have three efficient antibiotics, first line treatment, you choose the mostly inefficient one. The second one you use as the second line treatment, and the last one you use as a reserve treatment. This way, all the time, you will have a reserve in case of mistake. Mistake can be made by both the patient, if we are talking about ambulatory treatment. The patient goes home, applies the treatment. As soon as the patient feels better, he or she abandons the treatment. Afterwards, those pathogens you didn't succeed to kill will reactivate and the treatment will be inefficient anymore. So the patient could provide resistant strains. Or the doctor as well. If they never apply or rarely apply antibiotic sensitivity test, if they rarely apply generally any kind of bacteriological investigation, that also unfortunately happens. In this case, soon enough we jump from non-resistant to multi-drug resistant strains, from multi-drug resistant strains to extensively drug resistance, and from this one to pan-drug resistance. That means universal or total resistance. This also is called superbacteria. And last but not least, there are some pathogens that are making part of our normal intestinal flora. And talking specifically about gram-positive cocci, it is Enterococcus. Makes sense, right? Enteron in Greek means intestine. Coccus is spherical shaped bacteria. Enterococcus faecium. If you will read it, you will observe it is written faecium, and a lot of doctors are misreading it faecium. It is not faecium. In Latin, you observed everything that is written a-ye means e, right? Do you know it? So, Enterococcus faecium is a normal representative of our intestinal flora. And if by chance you will discover such pathogen in patients or in a ward while making sanitary bacteriological investigation, while checking which microorganisms we have surrounding patients, if by chance you find Enterococcus, or maybe talking about not only gram-positive cocci, but also other representatives of our intestinal flora I'm pretty sure you heard about Escherichia coli. Did you hear about it? It is the mostly spreaded representative of our intestinal tract, and you also should pay attention. If you find by chance Escherichia coli around patients, that means on surfaces in the hospital, on some tools in the hospitals, on the doors, and so on. If you find any normal representative of the intestinal tract in the hospital, it should be an alarm for you, because that means we have active contamination with feces. And it is not admissible even in our regular life, not talking about our hospital life. That means somebody has hygienic issues. That means somebody is not used to wash their hands after bathroom. That means maybe somebody is making bad disinfection in bathrooms in hospital, and so on. Please keep it in mind. All of us were humans. All of us were visiting the bathroom not once a day. So you should have kind of alarm in your mind as soon as you leave the bathroom, as soon as you skip the ward, as soon as you open one more door, as soon as you have a contact with another patient, as soon before any contact with another patient, and after any contact with another patient. All of these procedures, all of these events are considered to be potentially vulnerable points in which you could acquire or you could transmit some pathogens. Keep in mind, in the hospital, this is why a lot of doctors are used to call them pathogens, but not conditionally pathogenic or strictly pathogenic. In the hospital, basically everything is pathogen. This is why we have this deviation in opinions. But in the hospital, everything is pathogen. So if you don't have on your subconscious level this notification every time you skip the ward, every time you change your clothes, every time you go to bathroom, every time you take a meal, every time you have a contact with a patient, all of these are the vulnerable points in which you could transmit an infection. You could receive it, you could transmit it forward. As soon as you will fix it in your mind forever, you will upgrade your medical skills to another level. It is really easy in theory. It is really hard in practice, because such habits should be introduced in childhood, actually. So if you didn't succeed to do it in your life, please make it for your children. It's really important. Not only for those children who want to becoming doctors, but also for anyone. Anyways, it is a detail that seems to be too easy, but actually it is really complicated. It is really complicated to change someone's behavior, even when they're 20 years old. Imagine that you're a young doctor who is trying to change behavior of some doctors who are 50, 60, 70 years old. They have their life experience in this hospital, and you are coming in the hospital and you are saying, please wear your mask, not only on your mouth but also. Come on, kid, go and make your papers. It happens, and it will happen to you, because as soon as you will start working in a hospital, as a doctor, as a young specialist, uh, uh, you will have to learn something from other doctors with higher experience, and you will have something to give them. And not everyone will accept it, because it is impossible, almost impossible, to change even a teenager. Try to change the older one. It is almost impossible. As a result, we should work on the lower level. We should work on our kids. We should work on the growing up society. It's available for all types of lessons. Hygienic lessons, religious lessons, ideology, and so on. And you can observe that the mostly successful in this uh, in this direction countries are making the biggest accent on working with children, on implanting of some kinds of behaviors. Sometimes it works in the good direction with implanting good habits and good culture. Sometimes not really. So this is actually that direction in which you should work. Working on yourself and working on generations to come. And trying to feed somehow with generations who are older than you.